Well, good morning, everyone, or wherever you are, whatever time of day it is. I'm Peter Berman. I'm the director of the School of Population and Public Health at the University of British Columbia. And I want to welcome you to today's Voices in Health seminar on pandemic emergency financing response. As we always do, let me begin by acknowledging that we are privileged to meet on the traditional and unceded territory of multiple First Nations people wherever we are sitting, but especially our School of Population and Public Health on the territories of the Musqueam people and many of other facilities on the Squamish and Tsleil-Waututh peoples. And we're, as always, privileged to be able to meet on such a beautiful and historic lands. Voices in Health, a seminar series we launched last year, has been bringing in expert speakers from outside our school primarily, and a broad range of topics in population and public health and in global health. And this is our first event for the 2021 academic year. I want to let you know that we are continuing Voices in Health this coming year with many more interesting events coming towards us. And now I'd like to express my appreciation to Mike Law, who's volunteered to be our moderator and discussant for today's seminar. And Mike, passing the mic over. Mike, I'm passing the mic over to you.
Thanks, Peter. Welcome, everyone. Thanks for joining us today. It's my pleasure to introduce you all to Mukesh Chawla, who's going to be giving our talk today. Just to give you a sense for how things are going to go, Mukesh is going to give a talk until a little after 20 past 11, so about 45 minutes. I, as the discussion, will share some reflections on the talk after Mukesh is finished, and then we'll move into an audience question and answer period. So if you have questions, feel free to post them in the chat at any time through the talk. I'll monitor the chat and keep tabs on who's put a question. If you'd like to ask something anonymously, feel free to send it to me privately, and I will do so. Or you can wait until the end and ask your question over video. We'll make some time for that so people can put their hands up. So now for our keynote today. It's my pleasure to introduce Mukesh Chawla, who's the coordinator of the Pandemic Emergency Financing Facility and a senior advisor on pandemic financing at the World Bank. I won't read his very distinguished biography and history, but I'll post a link in the chat in a second if you want to read that off the SPPH website before, well, he begins his talk. Today, his talk is going to be entitled Pandemic Emergency Financing Response Notes from the World Bank. And I just ask that everybody hold off on speaking or asking questions until Mukesh is finished. So welcome, and over to you, Dr. Chawla.
Thank you, Mike. Thanks a lot. And thank you, Peter, Simona, everybody. I will be speaking for about 25-30 minutes, give or take. And what I will be talking about is developing integrated pandemic risk quantification and insurance solutions. So I'll start with a little bit of a background as to what the challenges are in this area of developing such kind of insurance solutions. And then we'll talk a little bit about the Pandemic Emergency Financing Facility that we developed at the World Bank as a proof of concept. And then we'll open it up for any suggestions, questions, reviews, whatever. So in terms of the background, as we all know, that the recent major disease outbreaks have changed the way that we look at all of the economic markets, and insurance markets are no exception. Not only is it that pandemics pose a huge threat to lives and livelihoods, but at the same time, they also distort the balance sheets of governments. Governments struggle to find money to pay for the response. They struggle to find money to pay for social protection. And as we know that in the current pandemic, which is COVID-19, IMF estimates that it is costing the world $500 billion month on month. And if we start counting that from the time that this pandemic started, then we are already in multiples of trillions. And if the global GDP is, what, give or take 90 trillion, 87, 90 trillion, then we are already in multiples of 3 or 4% of that already, and it is still continuing. Pandemics also pose a huge threat to businesses, aborted trips, canceled events, business interruptions. As you can imagine, they are costing billions and billions of dollars. The Olympics is one case in point. Interestingly, pandemics is perhaps the only event or only risk that hits both sides of the insurer's balance sheets. One, they lose their credit ratings, which causes the asset values, which they have to keep in hand to be able to pay out the calls on the insurance. And that raises the amount of capital then that the insurance have to hold. So there is a little minimum mandate that they have to do, and so they get hit on that front. At the same time, the payouts also start increasing. In COVID-19 alone, there have been over $7 billion in payouts that have already been announced due to the COVID-19 related shocks. But $7 billion may sound like a big number for most of us, but for the insurance industry, it is not all that big, even though the total amount of money that the property and casualty insurers, the P&C insurers, are estimated to lose over time is upwards of $200 billion. It amounts to only a small percentage of the total P&C premiums that they collect, which is $1.6 trillion. So you can imagine how big this industry is. This is only property and casualty. And there are many other things which are outside of this that also forms a part of the insurance. But pandemic risk quantification is a very special challenge, unlike other risk quantification. We have tons and tons and tons of data on auto collisions. Similarly, we have tons of data on healthcare seeking and costing. But we have very little data, very little information that will help us do the risk quantification that we need for pandemics. So it's not a straightforward exercise. Primarily because the number of recorded events is low. Take Ebola, for instance. I think at this point of time, with the 11th Ebola outbreak ongoing in DRC, we are in the 30th outbreak. So since, what, 1970, 76, when Ebola was discovered, from 76 to now, we have had 30 outbreaks. So I only have 30 data streams. So this becomes extremely complicated. I can run my deterministic models. They're very easy. However, there is a lot of randomness that is involved in pandemic risks, which is not captured in the deterministic models. I can do stochastic models. I know all about SEIR models, and we have all studied those SEIR models, and we can do that, and we can incorporate some aspect of random variation. But then I run into two problems. For us to run stochastic models, I have to take the data, say Ebola, 30 events, take that data and then multiply that data many fold. So for example, when we were doing the same calculation for the PEF, from at that time 28, at that time the 28 streams of data that we had, we generated over 600 million streams. And there are many ways, many standard econometric ways of doing that, but all of them come with their probabilities. And if you change something by 0.000001% at the beginning of the extrapolation, by the time you end, you are maybe in the region of 1%. If that 1% translates to a 2% or 2.5% effect on the premiums, you can imagine we are already talking about in multiples of millions of dollars. And this was one of the biggest problems that we had in the risk quantification. Most importantly, there are very few modelers in this space. In the commercial space, I can count with my fingertips as to how many do I have left. I want to say there are 3 that are left. When we started, there were 4. Then 2 fizzled out, 1 new entrant. I've got 3 modelers in the commercial space that are at this point of time modeling pandemic risk. There are hundreds of modelers doing other things. Pandemic risk, 3 of them. And that data, as you can imagine, is proprietary. It's a black box. It's very, very difficult to understand what really goes inside that. And in the academia also, we have seen a lot of models for influenza. We have seen, I'm aware of only 1, maybe 2, 1 Imperial College and 1 Yale. Maybe there are others. In academia, robust models, not deterministic, but stochastic models for Ebola. And that's it. So demystification of this process is also extremely important, both for us who are setting up this insurance, those who are buying it to believe in it, and for the insurers who are betting on it to also believe in that. So as you can imagine, this is uncharted territory, and we have tried very hard to find ways. And I would welcome any suggestions on what is it that we can do to demystify this whole process, and how can we make this so commonplace, and how can we generate hundreds of articles and work on this so as to demystify this process. At this point of time, that's not the case. And then there are many thorny insurance questions that we don't have good answers to, and we change anything a little bit and then we get into some problem. Coverage, what costs should we cover? Do we indemnify, or do we cover a cost, or do we give a fixed amount? If we indemnify a cost, how do we do the indemnification? What mechanism do I have? How much time will that take? Will it take too long? Then it's useless. Which pathogens I should be covering in this insurance? Who decides that? There are many unknown things. So this new coronavirus, for instance, what do? I know some families of corona family, but what do I do outside of that? Who are the beneficiaries? Companies, firms, governments, some other organization? Should we offer customized insurance packages? I'll take a break here and tell you a little story. When we were zipping around the world trying to offer PEF insurance to countries, in several countries in Asia, for instance, no names, I was asked the question, why am I interested in buying an insurance package that covers Ebola? Because I don't get Ebola. In 1 or 2 African states, I was asked the same question. Why are you including some things? Why are you talking of including Nipah, which we never included, when I don't get Nipah here, I get something else? Even within Africa, some states saying, why am I paying for Lassa? Lassa is only in some parts of Africa, and why am I paying for Lassa? So those are the kind of questions that keep on coming up. And if it is influenza, why am I paying for influenza? Because influenza will cover the entire world. So therefore, let the whole world deal with it. Why should I be paying for it? A very serious problem that we had when we were trying to market this insurance. Cash components. And on the payout, how much should we be paying out? We don't even know. Should it be covering the entire expenditure, entire cost? Had it been COVID-19 insurance, this is trillions of dollars. There's no insurance in the world that can pay for the trillions of dollars. What data should I be using? Whose data? WHO, CDC? Why do I believe any of these data? Why would the insurers believe that? Why would the country want to follow that? How do I put in a deductible in this insurance so as to balance the cost of the insurance? How will I enforce that? Am I holding that deductible like the Caribbean climate insurance does? Or should I be giving it to somebody? I don't know. How do I introduce preparedness incentives? In auto insurance, I give you a credit if you have a seat belt. Used to be that, not anymore, because seat belts are now commonplace. But I give you credit if you have a good score, or if you don't have any tickets or something. How do I do that? What is preparedness? Who measures that? Who pays for that? Sustainability. How will this be sustained year after year after year? These things only work over a long time period. I have an insurance for 1 year. That's a very different proposition than having one for 30 years. But how do I do that? How do I guarantee that? How do I make it statutory, like many insurances are? And we all know about health and auto. So these were the, these were the questions that we were grappling with when we started. And then we decided that we'll come up with a proof of concept. And that is how the PEF was born. So how did the PEF start? The stimulus was the 2014, 15, 16 Ebola outbreak. That is the one where we realized that countries need money upfront and they don't have money. What is it that we can do? It is absolutely true that all the 3 countries which were affected did get a lot of funding at some point of time, but not in the initial periods. I'll show you a graph in a second. Take a look at this one. This is a graph that maps cumulative deaths. These are the columns, the bars, the shaded bars, and the line graph that you see, that is the money that the world was able to generate for these 3 countries. The outbreak started in 2013, November, December. I have 76 deaths in March, 0 external financing. The cash-strapped economies of Liberia, Sierra Leone, and Guinea were rapidly running out of money. And this goes on and on and on like this, as you can see. And I am now in the month of August. I have 1,546 deaths, and I have got very little money which is in play at this point of time. I get to September, 3,083 deaths, only $88 million in play, as you can see, and going up. October, when you see the $416 million in play, by which time I have reached 4,941 deaths. This 416 million, bulk of it is coming from the World Bank. And then by the time I reach December, I'm in billions, and I've stopped counting after that because a lot of other assistance came in kind. So what we saw is that there was a very delayed response initially, and one can argue, we'll never know, but one can argue that that was one of the probably many reasons for this escalation in terms of number of cases and number of deaths. This was the single biggest motivation, that we had to find some mechanism of generating resources early on in the game. That is how we started. And then we looked around internally within the World Bank, what are the various mechanisms that we have? We looked at other agencies, what are the mechanisms that they have? And then at least the group that I was working in, we then argued that we think it was time to look at private sector financing, private financing for a public good. And that is how the idea of the insurance or the pandemic emergency financing facility came about. So I will skip this. We all learned many lessons from the Ebola epidemic. No financing mechanism. Whatever was there was not fit for purpose. We were passing the hat, asking countries for contributions. Some was coming, some was not coming. It was slow. It was fragmented, inflexible, ultimately way too expensive. Many new instruments came into being at that point of time. The joint external evaluations started just after that. IDA, which is our fund, the International Development Association, which is a World Bank's fund for the for the 76 lowest income countries, started thinking of preparedness plans. WHO came up with their contingency funds. All sorts of different things were done. One of those things which was done was establishment of the pandemic emergency financing facility, which is what I will speak on for the next maybe 10-15 minutes. So May 3rd, 2016, we sorted our own internal processes. We went to the G7 meeting in Japan, in Ise-Shima. PEF was launched with contributions from Germany and Japan. The trust fund was established shortly thereafter. It took us a little bit of time to go through the mechanics. and we went to the market on June 28, 2017, and I will come to that in a second. So first, who all was the PEF designed to cover? All low-income countries. At that point of time, there were 76 low-income countries, in which we know that preparedness levels are low, response capacity is especially challenged. These are the countries. And what you have here in front is just a sampling on a scale of 1 to 5, with 5 being sustainable capacity and 1 being no capacity. You can see a large number of these countries scoring between 1 and 2.5. There are some happy outliers here and there, but most countries doing extremely poorly. This is on the external evaluations conducted by WHO, CDC, other organizations, other experts, and the World Bank, and endorsed by the countries, and countries themselves acknowledging their own levels of preparedness. So we developed PEF as an insurance-based mechanism to provide surge financing. We twinned insurance window on top, and we put a cash window below for good reason, and I'll come to that in a second. We included all the beneficiary countries at that point of time. It reached up to 78 because some of them had graduated, but while we were in the process, when they were grandfathered in, the total size that we got of the insurance was 425 million, and I will explain why we got into 425, one not 400, one not 500, one not a billion. The cash window, which came from donations, around 65, 70 million. Started off with 65 as a target, it increased afterwards to close to 75. Which pathogens to cover? A lot of consultation, a lot of discussions with WHO and CDC and public health experts all over the world, and then we chose 6 of them. These are 6 of the 8 pathogens listed in or by WHO as the ones most likely to cause a pandemic. Pandemic flu, that's influenza. That's a novel influenza type A. Filovirus, that's Ebola. Coronavirus, we all know that we are going through now. Lassa fever, Rift Valley fever, Crimean Congo hemorrhagic fever. So we excluded Nipah, largely because we were not able to do the risk quantification of Nipah. We were struggling with that. The variations that we were getting were huge. And we set payout criteria, and we went with a predetermined threshold level. We call this parametric, which is that when you reach a certain threshold level, could be cases, could be deaths. I don't have any other metrics. It's unlike an earthquake. I don't have a Richter scale. I don't have any other way of measuring this. We played around with many others like deviation from the norm and stuff. It was very, very difficult. And we settled with a number of cases and number of deaths. And it was a very simple insurance in that sense. A country or more than one country hits a certain level of cases and deaths. Insurance triggers, a fixed amount of money gets paid out, no questions asked. You don't reach that level, but you still need money, which we believe that you do, then the cash window comes into play. That is not as automatic as the insurance window because that involves some judgment. Somebody has to take that call. And for that, we set up a little committee. We worked very closely with WHO, with their standing committee. And we worked at that time, David Heyman, I think David is still chairing it. So David Heyman and colleagues, and we worked with them to kind of advise us if the ongoing outbreak was serious enough to warrant support from the PEF, and we gave that support. Now, one can argue that really was this enough? So we did some analysis and we found that excluding the pandemic flu, pathogens not covered by PEF accounted for 70% of deaths due to epidemics in the last 15 years. So we mapped all the outbreaks and cases and so on. And you will see this on both sides. And so we looked at the outbreaks and cases, but once we exclude that, then we find certain numbers. There was some outbreaks that we did not include, that you see in the next slide. There's some diseases that cause significant morbidity and mortality were not considered: cholera, meningitis, measles, dengue, yellow fever, and so on. For a reason. If we found that there was something which was sort of endemic in a country, and therefore we expected the country's own public healthcare system to deal with it, we did not include it in the PEF. If we found that something had a vaccine, an established vaccine, at that time there was no vaccine for Ebola, we did not include it. If it was something that was vector-borne, we did not include it with the argument being that there were other mechanisms like the Global Fund that could possibly fund those outbreaks. So excluding those, we were left with those 6, and that is what we actually covered. The structure that we came up with was a comprehensive structure, and I will spend a little bit of time on this slide speaking about Class A and Class B. Class A included, please, I would like to draw your attention to the bottom of the screen to the expected loss, which you see at 3.57%. So these are events which are like once in 30-year type events. We call them Class A. The more frequent events, the 1 in 15-year events, we call them Class B, because Class B are likely to be more expensive because they're more frequently occurring. Class A events likely to be less expensive because they are less frequently occurring. So we separated these 2 categories. A pandemic influenza was in the Class A category. Coronavirus was causing us some problems, so we split up coronavirus into 2, and we put one end of coronavirus in Class A, and we put bulk of it in Class B. And all of this was dictated to us by the models that we ran. And as you can imagine, we did hundreds and thousands of iterations, and we kept on and kept on and kept on doing this. Covered the entire world, so which means that an influenza can start in the United States or in Canada and spread from here to some low-income country. That is then covered under the PEF. The beneficiaries will only be the low-income country, but for purposes of counting my threshold values, it would cover worldwide territories. And we did that deliberately because the airborne pathogens like influenza and corona could start from anywhere. It's just a matter of time that they spread to other places. So in Class A, we had influenza and corona, and Class B, we had phyllo, that is Ebola, Marburg, corona, SARS, MERS, etc., Rift Valley, Lassa, Crimean Congo. 3-year term, and events as reported by WHO through their disease outbreak news or the DAWNs or their situation reports. We agreed. This was a very difficult conversation, particularly with the investors, but we agreed at the end that we will go with no other data. We will not go with numbers from Johns Hopkins or from World of Data or from anywhere. We'll only look at what WHO is reporting. And then we set these trigger conditions. And we spent a lot of time going back and forth on these trigger conditions. And you can ask me, I'll just go with one example. You can ask me for flu is a bad example because number of cases increases dramatically. But let's say, for example, coronavirus. Why 2,500 confirmed deaths? Why not 2,000? Why not 5,000? Why not 3,000? It's because we worked on all of these numbers. We said, okay, so what if it is 1,000? What if it is 500? What if it is 10 deaths? What if it is 10,000 deaths? And then the attachment probability. Attachment probability is the probability at which the first payout happens. The attachment probability numbers were increasing dramatically if this threshold number from 2,500 was being decreased. So we went back and forth a lot. in between our calculation agent, which at that time was AIR, which is a Boston-based company, has offices all over the world, which was our calculation agent, our modeling agent, and conversations with WHO, with CDC, and the public health experts, trying to understand what would that right threshold be. And then we agreed at 2,500. We defined a pandemic very loosely as an event covering more than one country. So if it covers 2 countries or territories, that becomes a pandemic. This definition came to haunt us in the case of DRC 10th Ebola outbreak, which remained confined in DRC and did not spread to Uganda, Rwanda, or other places. We then calculated the attachment probability. That's the first point, or the probability of the first attachment of the insurance, 4.92 for Class A and 9.44, as you can see, for Class B. Expected losses 3.57 here and 7.74 there. And exhaustion probability is that when I will exhaust my entire amount of money that I have in my bucket. If I have 300 million, 400 million, 500 million as my payout, the probability that I will exhaust everything is 3.3%, which means that I can attach early, but I only pay a small amount. I don't pay everything. So there are some insurances that have high attachment, but low payouts and very low exhaustion probabilities. There are some insurances that have low attachment and very high exhaustion probabilities. We can play around with these numbers. And we took a position that we will not go with a high attachment and low exhaustion, because that would mean that I'm paying you early but not paying you enough. If I were to pay you $5 million at 500 deaths, I would have a much higher attachment probability, closer to 15%, 17%, and I would have a close to 0 exhaustion probability. And we said that makes it cheaper for us, but it doesn't serve the public health purpose. It was designed to speedily release funds. I will not spend too much time on this. This was something of extreme importance to us. The bank is a development bank. We are deliberative in the way that we give our loans and grants. Things take time, but we were venturing in a different world. So we wanted to make sure that we are paying out within days. So we set limits for us. Cash window, we would pay out in between 48 and 72 hours. And the insurance window, we would pay out as soon as we hit the trigger levels. And as soon as the payout dates arrive, we pay out. That could be 1 day, because the payout dates happen once a month. So it could be 1 day, it could be 29 days, but it was set at that level. It was funded by 4 donors. We went to many capitals. We knocked at all the doors. It wasn't an easy sell to convince countries to invest in this. At the end of the day, Japan gave us $50 million for insurance premiums. Germany gave us $17 million for insurance premiums, but much more money for the cash window. And Australia gave us a small amount, came in much later and gave us $7 million. We must have spoken with, I don't know, maybe about 20 potential donors, and it was a difficult conversation. Trying to sell an idea of an insurance that has never ever happened before. This was the first time that this insurance was being developed, and as you can imagine, it was a huge, huge challenge. So we launched this. We went to the market. My team and we were sitting at that time in the stock exchange in Zurich, and that is where bulk of the action was in Europe. And we split this up into Class A and Class B. Our initial guidance when we started was 200 million because we thought it would be too expensive for Class A and 150 million only for Class B. We were happily surprised when we got orders of 483 million for Class A. So we were oversubscribed by over 270%, which was amazing success. That showed us that there was tremendous amount of investor interest, obviously because of the returns that they were seeing, but also because of a potential that they were seeing in spreading their own markets and their own products and their own internal diversification. The final size that we settled on was 275 million for Class A and 150 million for Class B. And we split that up across bonds. The bonds are the catastrophe bonds or the CAT bonds. CAT bonds is the money that we take upfront from investors and keep with us. So that is not, we are already taking the money on day one. So 28th of June, this happened. 7th of July, we signed the legal contracts with them. And 7th of July, the money moved to us and we were holding 225 million Class A and 95 million Class B bonds with us. And of the swaps are derivatives against some other instrument, also secure. We are very conservative at the bank, as you can imagine. So it's 170. So we had 50 million of swaps for Class A and 55 million for Class B. When we started our pre-market conversations with investors, what we were hearing, 7.25 to 8% would be the kind of premium rate, and we settled at 6.9 for Class A and 11.5 for Class B. And 11.5 is a big margin to pay, right? So people were very happy, giving us this money for 11.5%, which is good for them and also good for us, because then for a small amount of money, I could buy this insurance. Why 425 million, as I had said earlier, is because I was governed by the amount of money that I have to pay premiums. If I had $200 million to pay premiums, I would have gone, or maybe 220 million, I would have gone to $1 billion. But the amount of money that I had to pay premiums was limited, was finite. So therefore, I could not buy more than this. We worked very closely with Swiss Re and Munich Re. Swiss Re were our book runners, and with Guy Carpenter of New York. So with these three experts who were helping us, Munich Re did a great deal of buying up, and they were the underwriters as well, both of them. And Munich Re was also allowed to bid and to buy or to get an allocation, but they had no part in deciding how much they would get. Swiss Re was doing the entire amount of the book running. I can tell you there were many investors who were very unhappy with us because they were not able to participate as much as they wanted. The same investors who called me just a couple of months back and said how happy they were that they were not able to participate because they would have lost all of their money because of coronavirus. But that in hindsight. So we simultaneously offered both risk and bond, both bonds and both CAT bonds and swaps in the market, and we were able to distribute across a different class of investors. We wanted to spread out as much as we could because we were eyeing the market. And so we went to as many as 52 different investors, CAT bond funds, reinsurers, asset managers, pension funds, endowment funds. Bulk of the action, as you can see, was in Europe, a little bit in the US, because US was already exposed a lot to business disruption insurance and to climate insurance. We got a little bit of action from Japan, not too much, and Bermuda, 0.1% and 11.3%. I was hoping this would become bigger and I would shift my headquarters to Bermuda, but that was not to be. When we look at the total amount that we were paying and we said, okay, what if every country paid their own insurance? How much would that cost? It costs 2 cents per person per year. That's it. Now, obviously, all of these calculations are a little bit, you may say that facetious, because it's like, it's like saying how much do I spend per day on my house insurance, and so it's like that kind of a calculation. But we wanted to do this particularly to see the percentage of premiums, or premiums rather, as a percentage of health expenditure. Take Liberia. Liberia would have had to pay a certain amount of premium. And on the basis of that premium, when we did this calculation, we found that they would have had to pay an extremely small amount of their expenditure on health. Liberia spends very little on health as it is. And of that, an extremely small percentage, that's what you see on the right-hand side axis. And Liberia, if we had this facility up and running during Ebola, Liberia would have been a massive gainer, would have received $150 million out of this. But that is probably true of all insurances. But so for individual countries, this was not a bad deal. But it only works if all countries join. If only one country joins, if Liberia were the only country buying Ebola insurance, then the insurance would cost them more than the payout because the likelihood of an event happening there is extremely high. But if Zimbabwe were to buy it, for instance, but why would they buy it? Because they don't, it's not a zoonotic reservoir in Zimbabwe, so why would they even buy it? So we had to pool the base, and that was also one complication as to how do you pool the base if you have a market mechanism? How do you make sure, unless it is statutory? A parallel to this is private health insurance and public insurance. You run into all sorts of problems of adverse selection if that is what, if you go to the market, which is why we had to step in. We did a number of simulations. Had the PEF existed earlier, it would have triggered as early as May, which is the second month of the H1N1 flu pandemic in 2009. And paid out $275 million right there. Come back to this graph which I showed you earlier of Ebola in West Africa. And please look at the bar on September. The PEF would have triggered in the month of July and would have paid out, between June and July, would have paid out $45 million right there and then. And would have paid out a further $150 million in September, much before other big monies started coming into play. Now, I dare say that that may have contributed in some part, no part, all part, I can't say, but definitely would have contributed to the response itself. So that was extremely important. Had the PEF been there at that point of time, we would have paid out much earlier, 45 million, then 45 million afterwards. And by the time we get to September, would have paid out 150 million US dollars. The big amount of, the first big money that they got from the World Bank, that came from the World Bank, and that only came in October. And this may have been a game changer. So come back to my last slide. How did this all play out? And how did the PEF play out? What is the PEF in action? In the life of the PEF, we started July 2017. Since then, the PEF has made 4 payouts in the last 3 years. We made the first payout in May 2018, 11.4 million. This was WHO, DRC, other partners, UNICEF, IFRC, other partners had put together a response plan of $43 million, and they were falling short by $11.4 million. We paid them this money. We made this money available to them in the month of May, sometime towards the end of May. And by July, this is in the Equator province, Northwest DRC, and by 28th of July, this outbreak was declared over. And we became the second largest funders. The PEF was the second largest funder of DRC's response to the 9th Ebola outbreak. February 2019, or even earlier, August, September, the 10th Ebola outbreak starts. And this starts slowly in North Kivu. And we made the first payout of $20 million from the cash window. Again, there was a huge shortfall in the entire response plan that was developed by DRC together with partners. And there was this gap of $20 million. And I still remember this time vividly because I was sitting in Goma in DRC at that point of time. And we could see that there was tremendous amount of shortage of funds. We made available 20 million then, followed that up a few months later with $30 million. So total of $50 million that we paid, and we again emerged as one of the 3 largest financiers of the 10th Ebola outbreak in DRC. Even as we speak, just this morning, we allocated $2.2 million to the 11th Ebola outbreak, which is also the gap that they have. Well, the gap is slightly more, but I only have $2.2 million left in my cash window, which I've just allocated this morning to DRC. March 2020, March 31, 2020, the insurance window triggered for the first time. But just a word on this, on the cash on the DRC 10th Ebola outbreak. We came under tremendous amount of fire for the 10th Ebola outbreak because that led to over 2,800 deaths. But the insurance window did not trigger because the insurance window was designed to trigger if it is more than one country. And this outbreak stayed confined to one country. It had to have 20 deaths in one other country. We did record 3 deaths in Uganda, so here we were sitting in Goma, working very closely with the government, but unable to trigger the insurance window because those rules were cast in stone. Those were announced, declared, on the basis of which the investors gave us the money, holding us in trust, and the insurance window did not trigger. We got very badly beaten for this. We got beaten for many other things, which I will come to in a second. On March 31, at that point of time, in IDA, in my low-income country, which are my beneficiaries, I had 4,623 cases only. 4,623 cases only of COVID-19, and 78 or 79 deaths total in IDA countries. And that is when we triggered. And that gave us 195.84 million. So my investors lost $195 million in this process. They may have enjoyed their return of 6.5% for some and 11% for some. At the end of the day, the total payouts that I made on premiums is $101 million US. And in return, the investors lost $195 million US just in 3 years. It's almost like buying an auto insurance on day 1 and having an accident on day 2. Insurance is a terrible thing. You only win if something terrible happens, and in that way it is a very dreary business. And because we found ourselves counting deaths, which is a terrible thing to do. And one other reason why we got beaten up, that we only paid out when a certain level of mortality occurred. But frankly, we had no other indicator. Number of cases, there was so much of noise in that we could never understand whether we had the right number of cases. It depended so much on many things, but we had much more certainty when it came to mortality. Even there was some noise there, but not too much. And this 195 million then gets spread over 64 countries. And then again, we are now getting beaten up that we are giving only small amounts to these countries. Now, on average, countries are getting $3 to $3.5 million. Some countries are getting 15 million, Nigeria, Afghanistan. The larger countries are getting bigger amounts. The smaller countries are getting much smaller amounts. So we put a floor of a minimum of 1 million. We put a max of 15 million, and we spread them between 1 and 15, depending on the number of cases that they had reported on that day. And yes, it led to a tremendous amount of problems because the amount of money that we put in is small. And the reason the amount of money is small is because that's the sum total of insurance that I bought. The total insurance which I bought was 195.84 million for coronavirus, and I paid out the entire amount of money. So in short, as a proof of concept, what it tells us are three things. One, there is a market for this. It's very early days yet. This is a market that has to be developed. There are many unanswered questions. Our quantification, our risk quantification has to improve, has to become transparent. And all of us have to believe in those numbers. It's not easy because, as you can imagine, when you're running any probability model, each time you run a stochastic model, you'll get a different answer. So depending on which day of the month or which hour of the day or which second of the minute you stop running, and then you stick to that particular result, and that can affect the range of millions, as you can see. So serious issues to do with pandemic risk quantification. We have started the ball rolling. There are a number of people in academia who are doing this. There are a few companies in the commercial space that are doing this. We want this process to expand dramatically so that it gets demystified. The second problem is how much, what should be the size of the payout. Had this 195.84 or if it is influenza and I'm paying out 275 million, 300 million, you may argue that's a drop in the bucket because you probably need in billions, and you're absolutely right. So how can this insurance ever have salience? The third biggest problem that we have is most insurances are binary in nature. They're not slow moving like this one. An earthquake happens, an accident happens, a hurricane happens. Health events are a little bit more slow moving, like personal health, but that too is pretty binary. I wake up in the morning and I have fever. So there's some indication. This one is very slow moving, and it takes a time, and it goes up slowly, and people start getting anxious and unhappy when in the early days of the outbreak and insurance is not kicking in. It's a very, very serious problem. There is no other insurance like this that we are aware of slow moving risks like this one. So these are the three big challenges that we see. The fourth one, of course, being, supposing I have a viable product. The product has one nature of viability if I have one buyer, and one nature of viability if I have 100 buyers. And we see that also in our personal health insurance. So how do we make sure that it is spread across and everybody buys it? How do I get that collective action in this? And it is extremely difficult. In this proof of concept, we brought in the collective action by having donors pay the premiums, which led to another problem, because since the donors were paying the premiums, many of my beneficiaries had no idea what the PEF was. And we held series of conversations with our donors. We probably covered maybe a little over 50 of the 70 plus in direct face-to-face conversations. But then things change in governments over the years. Somebody else comes, people forget, things get pushed in files, and then when it comes for some action, all that they have is what they see in the media. And there were all sorts of people giving their commentaries, and one of our favorite commentator is here in the audience, but there were many other commentators who were not so nice. So this becomes therefore a mixed bag. So early days yet, as a proof of concept, we believe that we are onto something. As a proof of concept, we believe that there is a market, that it is something that should be continued. Who else to do it but an organization like the World Bank or others or some big countries? There are some efforts which are ongoing just now. African Risk Capacity, or ARC, in Africa. They're already in the climate insurance space, in drought insurance particularly, are also exploring possibilities of pandemic insurance. but they're much smaller in scale than even us. So maybe we need a little bit more salience. If we start getting some middle-income countries, high-income countries joining, that of course is going to be a game changer, because that will suddenly allow much of a spread, and so therefore much more of balancing the risk and sharing the risk, and that's going to change the name of the game. But early days yet, and I'm going to stop here and take any questions or comments today or later on. You have my email, but I turn it back to you, Mike.
Thanks very much, Mukesh, for a really interesting and excellent talk. So I see that there's some people leaving questions in the chat already. Please feel free to do so. And if others want to ask questions live, then please feel free to use the raise hand function, which you can find under the participant list if you click that button at the bottom. I'm just going to offer a few thoughts here. So before the talk today, over the past couple of days, I've gone and read some of the literature and the news stories about the PEV. And as Dr. Chawla suggested, this is a new tool, and it has been subject to some pretty significant criticism in the both in the media and in the academic literature. I put forward that it's probably the case that any tool would be getting creamed right now because it's not sufficiently responding to the pandemic that we currently face. And there's a lovely line in a Financial Times, in response to a Financial Times article, that critiquing this program, and I quote, reminds one of a petulant spouse complaining about his or her partner's expenditure on a fire extinguisher when there is no fire. Except this time there is a fire, and this fire requires a more powerful extinguisher than the one purchased. So, turning to those critiques, I just want to highlight them a little bit for people so that they understand where some of those have gone. The main ones have been about the high interest rate that the funds paid to the people who gave money to these funds, and at the same time criticizing the tough rules for the payout of the funds. So it's been criticized on both, and Dr. Chawla did indicate some of that, or did touch on some of that criticism of the lack of a payout in the DRC in one of the Ebola outbreaks because of the second country not being affected. The tough thing is, and I had to remember this while I was reading this, is that it's hard to be dynamic with these kind of programs, right? Outbreaks differ, diseases differ, they have different characteristics and whatnot. And the rules, in essence, you have to guess. So they had to guess in 2016 about what the rules should have looked like. And so the 12-week window for paying out, so the pandemic has to last 12 weeks before the payout happens, has been criticized. But if it's too short, you risk unnecessarily spending money. And if it's too long, you risk missing your opportunity to intervene. So thinking through whether these bars were set too high or too low at this point in retrospect is really tough. You have to think about this from 2016 and whether they were appropriate at the time. So the critiques of that at the same time have to think about whether or not the interest rate that they're paying out is too high or too low, because those things are intricately linked. So if you think about people criticizing the interest rate on the fund, but also criticizing the rules, if the rules made it easier for a payout to happen, then the interest rate would have to be commensurately higher to compensate investors for that risk, right? And so you can't criticize both. Either the rules are too strict or the interest rates are too low. That's it. You have to choose one or the other. That's simply the way it works if you're dealing in private finance, or else you get nobody investing. What I think the real question is here, and the thing that the PEV should probably be evaluated on, is what does the world look like now that we're in the middle of a pandemic without this program in place? So without the PEV, would we have found $195 million for low-income countries this year, absent the existence of this program? I think there's not a chance. We were frogs in boiling water from December to March while this crept up on us. And then when we all suddenly awoke, we were in the midst of unprecedented spending by governments in high-income nations around the world in order to try and mitigate the effects of COVID-19 in their own countries. to think that they're going to stretch those budgets to come up with an extra $200 million to send to lower income countries, I think is foolish and a real stretch. So in that case, in that respect, I would say that PEP has probably been a success in getting more money to those countries than would have been. So better than we would have seen in that counterfactual world. The success, of course, is impossible to prove. We don't know whether this funding made any marginal difference in how COVID is spreading or what these countries would look like without it. And this, of course, leads back to a problem in pandemic preparedness in every respect, is that we don't have identifiable victims. We'll never know who was saved by any of these interventions because that counterfactual world is very tough to think about. So then the last thing I'll mention here, and I'd love some from Dr. Chawla about this, is Dr. Chawla argued in his talk that, quote, there's a market for this. And so I've been thinking about, during his talk, about whether or not this is something we could use in the future. And I honestly have a bit of skepticism about it, and I'd like to hear his response. When we were talking about MERS and Ebola and avian flu and other threats that people could discount easily that were happening over there, not happening here, but happening over there, it was seen as something that people could, investors would see it as something that was less probable, because you're essentially betting with a bond. You're betting that the event doesn't happen, so you get the interest but don't lose your funds. But in investing, people have a real recency bias. People have this bias that what's happening now will happen forever, or it's more probable than it probably is. So would it work if it was proposed now? And I would worry that investors would look at this and say, well, geez, COVID happened 2 years ago. I'm not going to invest in that because the next pandemic's probably right around the corner. So I don't know whether or not this happens. And the World Bank did announce this year, and I'd love to hear more about this, that it wouldn't issue new bonds into the fund. And I'd like to know what's behind that decision. So that's my comments in short. I'm going to turn it back to Dr. Chawla for some response to that question. And like I said, please raise your hand or post some questions. We have some already, and I'll be turning those back to Dr. Chawla as we move along.
Thank you, Mike. Excellent comments. I'll only just take the last one that you mentioned about there being a market or there not being a market. So the reason why we believe that there is a market is because we are hearing from insurance companies almost on a daily basis. Even this morning, somebody heard that I was going to talk today, and I want to read out the message which I got. And what they said is that the cat bond investors group, that they're asking us to start the next round of PEF because we will never get such a great deal again if we come back with the next pandemic deal 1 year later. We are absolutely shocked that you think that you got a bad deal the first time round. Obviously, they're saying this, but at the same time, the premiums that they're asking for, when we did a pre-market check, this was in February, March, the premiums that they were asking for was significant multiples. The premiums, as you know, are multiples of the expected loss. So instead of the expected loss numbers have gone down. For Ebola, for example, it's gone down dramatically. The expected loss has become half because we now have a vaccine for that. And once the vaccine gets widely used and certified, it'll probably go down to close to zero. But just now it is down to 1% compared to a little over 5 just for Ebola alone. But the premiums that the market is asking me have gone up from 160% to over 500%. So just now, things are tight. It's exactly the same thing. I have been in the last 3 months, I've been in the business of working with low-income countries and helping them get the medical supplies, the PPEs and the equipment. And the variation of the prices in PPEs, all of you are familiar with, I don't need to go into that. So these are awkward times and the market environment is a little bit crazy. But I do believe that there is a tremendous amount. There's an article that came out in The Economist, which I'm reading as I speak. This is of July 24th, 2020. is called insurance premium on change, which gives us some numbers of some extent of where the market is. What we are hearing now is much of this market getting into business continuity and business interruption insurance. That is where they are going, much more than pandemic insurance, a la mode, the PEF. But you're absolutely right. This is a tough one, and we can't decide at this point of time. Maybe next year we may have a slightly better idea. At this point of time, since the premiums were so high, we decided that we will take a pause here and go back. Unsatisfactory response to your question, Mike, but that was a tough one. Let me go through some of the questions which I'm seeing here. This is from Karan. Could you repeat why some countries benefited? My apologies if I misspoke. It's not the countries, it's the insurers who wanted to sign up, but because we were limited in what we could buy, they did not get that opportunity. And so they don't have to pay out now for coronavirus insurance. So they ended up saving money. In hindsight, we are all very happy. What proportion, this is from David, what proportion of PEF money have governments used to pay for in-country needs like income support for individuals, local production, distribution of essential goods versus out-of-country costs like purchase of foreign goods or services? Excellent question. I can answer that for Ebola because we have those numbers. I don't have the numbers for Corona just now. It's early days yet. The entire amount of money went for income support for individuals, nothing to do with local production, but paying their frontline staff, giving them hazard pay because Ebola, as you know, it wasn't easy at all. There were a lot of problems of law and order, particularly in North Kivu. So that is where bulk of the money went. Purchase of foreign goods, yes, some foreign goods had to be purchased, particularly drugs, and but they came to us at cost price to the government via WHO. For in-country needs, what are the relative merits of buying insurance versus a monetary policy response like printing more money? Happiness, we could print money, accepting that most of these countries, for them to print money and enter into seigniorage, it's going to kill their economies because the inflationary pressure is going to be extremely, extremely, extremely high. I would much rather commit $1 million than end up printing notes worth $200 million. And particularly in low-income countries, even for high-income countries, that's going to be a huge, big hassle. Fiscal response, one can think of, yes, but most of my low-income countries that we work with don't have that kind of fiscal space to play around. Finally, what mechanisms exist to ensure money received by an insured government actually will be used for credible public health activities at non-profiteering prices? Good point. I don't know. We have struggled with this, and this is true not only of the PEF, but this is true for all assistance, and the same rules apply. Not only for assistance external, but also for internal. So I guess much would depend upon the governance play in the country. And this is an excellent point. It has bothered us a lot. We don't have a good answer for that. We normally, during an emergency like this, we work on a no regret mode. And because you are seeing real losses of lives and livelihoods. So it's not easy, but it's an excellent question, David. Karan, again, could you please explain how exactly a faster cash infusion helps with an early pandemic response? Oh, of course, yes. If I need money up front, if I need money to launch a response immediately, I can snuff it out. But I need money for that. I need money for everything. I need money for transportation. I need money for drugs. I need money for surveillance. I need money for containment, for quarantining people, for separation, for Ebola. I need to create specialized units in the hospitals. All of these cost a tremendous amount of money. And I need that money early, very, very, very urgently. And if I don't get that, 11th Ebola outbreak, that's what happened. They got no money. DRC got no funding of their own money. They had very little left in their own treasury. and it has lingered and lingered, and now it is now growing. So early money definitely helps, but of course it has to be spent wisely. As in, how much of an effective early response is actually hindered by a cash shortage versus other factors? For low-income countries, I would say a lot, because they are strapped for money, and that's what they need to start buying things. Of course, they also get contributions from abroad. What we have found is that those contributions come in much later. They don't come in at the early stages of the outbreak. We saw that in the case of the West Africa Ebola outbreak. We are seeing this now in the case of the 11th Ebola outbreak. We saw that in the case of the 9th Ebola outbreak. They needed just $11 million, and they were not able to raise from any of the donors. And it became a very, very big problem. And there is a certain minimum that you need that it costs to, for example, establish an isolation unit. So cash shortages do hurt. But I see where you're going with this, Karan, because it's not the only thing. And we totally agree with you. Money is not the only thing. There are many other things that come with it. And I totally agree with that. We were only contributing to solve a part of the problem. Dr. Erickson has information. Thank you. Karan, again, how do you ensure you are getting reliable mortality figures from countries? I don't, which is why I go with WHO numbers. I don't look at country numbers. Yes, WHO gets their numbers from countries, but I leave it to WHO to figure out whether those numbers are good or not good. But whatever WHO reports, I go with that. Zabir, does the risk quantification model account for population behavior? Yes, like movements, absolutely. Such as trust in government. Good point. No. In the model that we used, the SEIR models and the traditional SEIR models don't have things like trust in the, we can't use anything that we can't quantify. And using dummies in stochastic models like trust in government is a little bit shaky, but we do have population behavior in terms of movements. Also the capacity of country, same argument. Corruption, same argument. Would it be possible to create a counterfactual analysis showing the impact without PEF? Whew, that's a tough one. I don't know. And maybe we could try that. As Mike mentioned, that is not a useful one for COVID-19, but definitely would be a useful one for a counterfactual without the PEF for Ebola. The 9th Ebola outbreak is the most helpful one. And we could do that. That is a good suggestion. Maybe then we can get more buy-in. Yes. And I'd like to know, Dr. Erickson, why the World Bank did not pursue PEF 2.0. It's very simple, Susan. Economics. The demand that we were hearing in the market, the premiums that they were asking were too high. They were asking for between 15 and 25% premiums. And I thought I would be paying less than 10% now, even for Class B, because my probability numbers, only thing that has gone up is the corona probability went up from 3% to 5.8%. But everything else came down dramatically. And corona, once I have a vaccine, will come down also dramatically. But just now the premium demands were way too high. And so it was just very difficult. Karan again, won't an influx of money from abroad also create the same inflationary pressure as Sanuraj? Yes and no, because this is new money, it's not old money, and it is buying goods and generating a system of the economy, and but it does create an inflationary pressure. But the influx is not all that big, and yes, you're absolutely right. It does create an inflationary pressure. We saw that in the case of DRC itself. All of a sudden, particularly in North Kivu, in Butumba and other places, there was a tremendous amount of money, and the demand for things like motorcycles went up dramatically. So yes, so there was an inflationary pressure. We don't have numbers of effect on food prices. That's the only thing that we were tracking, and largely because we don't have a good denominator. But It does, but I want to argue much less than Senor.
So,
I don't see any
Dr.
other
Chawla, we're actually getting close to the end here, so I'm just going to take moderator's prerogative to ask you one last question to close us out. I just wondered, as someone who's so intimately involved in the design and early sale of this, what would you do differently if you could go back to 2016 and we're designing this again?
You're on mute, Mukesh, you're on mute.
My apologies. One thing I would do differently is go back on risk quantification. We were struggling with risk quantification largely because we had the best company in the world, very robust analysis, but our level of understanding at that time was very limited. And if I were to do this differently, I would bring in a much larger panel of experts to work with me on risk quantification and to get that down. Second, I would design a slightly different product. I would design a hybrid product. I would do single country and multi-country. For certain things, I would go single country, and for certain things, I would do multi-country. And so therefore, I would be able to differentiate my pricing, and then I would be able to come together with a composite pricing. We did that analysis, by the way. And then when we were getting ready for PEF 2.0, it would have looked a little bit different from PEF 1.0. And it would have then paid out, for example, would have paid out to DRC Ebola at 1,000 deaths, not at 2,500, or not paid out at all, as in this particular case. So that expense went up, but certain other things went down. So we would have played that little bit of balancing there. So we would have done that differently. Third, I would have completely changed the way that the donors paid the premiums to me. The donors paid the premiums, they wrote a check to me, and that did not help. I would have gone through the most onerous and complicated process of donors paying the money to the countries, and having a bilateral agreement with the country, and the country having a bilateral agreement with me. And the money would have come straight to me, but I had no country buy-in at all. I had zero country buy-in. Except in the countries I worked with, 4 or 5 countries that I worked with very closely, I had zero country buy-in. I would go to them, I would explain, and they would say thank you, and that would be it. Fourth, I would struggle. I don't know how to do that, but in the ideal world, I would try to look for a way in which I would link the payouts with preparedness numbers. That was getting to be a bit awkward because that would have penalized my low-income countries if I link it to preparedness. But I have to have some measure of doing this. But I don't know. I don't know how to do that. Live and learn, Mike, and I think it would need many iterations to kind of get it right. First time that we are doing this. Also expensive, therefore the markets are also learning. They're also getting more confidence in this, and it's like the first time. I still remember the first computer that I bought, a desktop computer which I bought way back, was $1,400, and today I can buy a 25,000 times powerful computer desktop for less than 1/5 that price. So things improve as we go along. But I very quickly take Peter's question, which is based on your experience at this time, at this moment in time, do you feel that private capital can much more significantly respond to a global crisis like this? Oh, 100%, absolutely. Because all the insurers that I've been talking with, particularly in the PNC space, which is property casualty, and in the life space, in insurance, when they pay you at death, they call it life insurance. We ought to have learned from that. The PNC folks and the life folks, when we look at as to what exactly they are doing, we find that they are also extremely keen for this kind of diversification, because this is something that hits on both sides of their balance sheet. So this is actually plays for us. They don't want their own asset values to decline. Their asset values go down. They're forced to either kind of liquidate their holdings, in which case they get hammered, or to borrow, in which case they get hammered. So they are stuck in between there. So they're extremely happy in this kind of diversification. And this is the pressure which I'm getting. It's not because they love pandemic insurance and they want to do this great good. I'm sure there are some altruistic motives there as well, but mostly because they're desperately keen to do this diversification and to pad up one side of their balance sheets. So I do see a tremendous amount of potential. Do I see that right away? I don't know. Will I be able to buy it myself because of the high premiums? Probably not. Is there a future in this? Definitely yes. Will the future come more from the private sector insurance for private goods? Absolutely. Will it then translate into private for public goods? Most likely yes. Maybe not in my lifetime, but I'm sure that it will happen.
Great. So with that, I'm going to take this moment to thank Dr. Chawla very much for a really interesting talk and some great discussion afterward. So if you could join me in thanking him for that. And I will turn it back to Peter to close us out.
Great, thanks. Thanks, Mike, and thank you, Mukesh. It's especially gratifying for me personally to have been able to invite Mukesh to share this amazingly interesting experience with us. We worked together many, many years ago on some very different things. And it's been really so exciting for me to see him get into this completely new and very interesting and challenging field. Just to give a couple of thoughts in closing, I think this has been a very interesting talk from several dimensions, and I think, of course, our time is limited, but just to highlight some of the things I'd like people to think about, there clearly is a lot of public health in this enterprise, and you could hear that in all the details about how to estimate, guesstimate, measure risks, bundle different kinds of risks together, quantify these things. The evidence that goes into much of this thinking is epidemiology and infectious disease research, as well as the question of what to do with the funds if the funds do get paid out, and what difference does it make. So there's a public health dimension to this. There's clearly a market finance dimension to this, and that links to this broader question of private capital and development, and whether there is an untapped potential for mobilizing greater private capital for what are typically not seen as the purely economic goods, but more the social goods, health, education. We see many experiments in this area going on around the world. I think the PEF was one of them. But it was an interesting one in the sense that most of what we see today are fairly circumscribed, narrow risks that private capital takes, specific projects, specific payouts, and so on. This one opened up the door to a systemic risk, a global systemic risk that clearly we knew could happen, but how to capture that in a market-based structure really was a very challenging question. And then, of course, we do have the questions about where this goes in the future. So I want to take another moment to thank Mukesh. It's really been a fascinating time we've been able to spend together. I want to acknowledge as well others who have contributed. Mike, thank you so much for your very interesting questions and comments. And I want to thank Simona Powell and Alexandra Warren, who help us organize these events, and Stefan and Kevin, who manage the IT side of this. All of us work together to bring these events to happen, even today in our pandemic-affected environment. So one of the responses to the pandemic has been the ability to hold these Zoom seminars, which enabled us to bring Mukesh in at zero travel cost. So thank you for that. And just to take my final note that the Voices in Health will continue this year on a monthly basis. Our next seminar is October 29th. Stay tuned. We promise you an interesting set of events for the coming year. And as far as we know, we will continue in this Zoom-based format until all the work that so many of us are doing finally brings this terrible pandemic to a conclusion. So thank you all, and wishing you well for the rest of the day.
Thank you, Peter. Thank you, Mike. Thank you all.